Okay, we are recording. So, good morning, Dr. Wheeler. How are you?
Good morning. I'm great. Thank you.
Thank you so much for agreeing to join me this morning to talk about grief and loss and help me to enrich the class I'm teaching in the fall for the first time, which is the grief and loss class, the MSW elective. Everyone in the class will be an MSW student, and I know they are all going to benefit from hearing your lens on grief and loss and how they can work as emerging clinical practitioners in this space and give the folks they're working with the time and relational factors that they need to have that space we've been talking about, that within which people can grieve and heal and sort of feel freedom to be honest about what's going on. So
Yes, absolutely.
you want to talk a little bit about yourself and who you are and where you came from, and you teach here now?
Okay. I'm Dr. Wheeler, and I am an FAU alum. I graduated with my DSW in 2020 with Dr. McClellan. And previous to that, or I guess currently, so I have a private practice, and now I teach part-time at FAU, and it is a wonderful blend of two practitioner, instructor, clinical social work lenses that I have loved for the last few years. I teach in the master's program, I teach social work and spirituality. And then I also teach in the bachelor's program and in the doctoral program about supervision. Where I come from, I went to my MSW, I went to Michigan. And I came back to Florida in late 2008 and have been here ever since in practice. Started my social work career in New York City in hospital social work, which was a wonderful foundation for everything we do. Uh, and then have pretty much always been clinical, except for a year and a half. I was in administration, which was not for me. But every other position I've had, inpatient and outpatient, has been within clinical practice. Um, that's about it, I would say. I love dogs. I love yoga. I can talk about those things, but maybe not in this space.
Oh, you never know. You never know. We're going to
That's
talk about
true.
our authentic selves, so who knows what will come up.
That's true.
So, in this class, students are learning about Francis Weller's Five Gates of Grief. I showed you the book that we're using to frame our work this semester, The Wild Edge of Sorrow, Rituals of Renewal, and the Sacred Work of Grief. And I asked you to talk today about the second gate, which is the places that have not known love. And that includes parts of a person's life that may have been neglected or shamed or rejected or silenced or never really fully welcomed. And when I think about this, I think about, like, from a psychodynamic lens of splitting off those parts of ourselves that we reject and feel shame around, or from an internal family systems models of really hiding those parts that are so anxious and afraid, and we protect them by never letting them see the light of day. But what Dr. Weller proposes is that if we split those parts off and they're never able to be seen, then they are never held in compassion, right? And they are the parts that become that internalized shame, whatever that looks like in our practice, in our lives. So as we work this semester together, students are working to learn to not rush clients towards insight or closure or symptom relief because we want to rescue them from pain, instead about welcoming those parts that have never been welcomed. So when you hear that phrase as a clinician, the places that have not known love, what does that bring to mind for you? What does that bring up for you?
Well, I mean, several things. I mean, thinking about what you talked about in terms of splitting, I conceptualize that, a lot of the word that I often hear in my practice room is compartmentalized, and so I think about splitting as this method, or defense mechanism that we use as a strategy to put things that are really difficult to deal with aside. And then there are all different, levels of the spectrum of how much we do that, to the point of perhaps, active psychosis, that it's split so far that we may, create a personality or not be able to access it. So I think about that, and certainly about the splitting. Um, but something else that you said, is that they, in terms of how she characterizes this, is that we we really have trouble accessing them or touching them or holding them in a space of compassion, certainly, especially when you're talking about grief. And so being able to access some of that is incredibly difficult, to the point of, not being present in your mind. And so
Mm.
when we're dealing with clients in that way, I think that's, first of all, I would say the first thing I think about is assessing for that level, and asking really in-depth assessment questions about something that has to do with grief or something that's related to grief or shame or trauma. Um, that's the first thing I think of when you say that, in addition to the splitting part. And the second thing I think about has to do with the space that we learn to hold. Um, Things that are not ever shown compassion or not ever reached or touched, that is also really hard for us as clinicians to hold that space. And so I think we really get to understand who we are as practitioners and, understand that we're going to get to potentially do our own work or some kind of support and self-care as we go through that process. Because it may bring things up for us that potentially have never been touched, that we didn't even know were there in working with clients in this capacity. So those are the first things I think about. That helps.
Because we felt shame about them, so we squirreled them away. So they're emerging not just to the clinician, but perhaps to the client themselves.
Right. And depending on how you practice, part of my practice philosophy comes from a psychodynamic lens. So I am going to use, transference and countertransference response in terms of understanding, what I'm feeling in that space. And, it's interesting practicing for the last few years because I think it's sometimes, it's evident in in-person sessions, but it's also incredibly evident in this kind of session. In terms of practicing telehealth, I think maybe feel and experience some of those, countertransference or transference responses even more because I'm just focused on this part of a person, whereas in the space, I'm focused on the whole person. I really do use that in terms of accessing, what I'm experiencing and what I'm thinking about, what comes up in my mind cognitively in terms of what's being said or not said, right? Verbal and nonverbal from a client.
So that awareness. It's interesting you comment on the telehealth environment leading to perhaps even more attention to like the nonverbal stuff that's going on and the countertransference. I think too that as practitioners, we feel the ability to be a little more vulnerable in our own space. I've talked, I think probably to you, I know I've talked to my clients about the fact that I know every noise in my house, this is my home office. So I also am a little more open and vulnerable in this context than I would be in an office space that I shared with others. I had a receptionist or offices around me with noises. So I think it's interesting that we have learned that telehealth can actually lead to more awareness of
True.
some of that. It's fascinating.
I
It's
think even going into it, I think that was sort of, we kind of dove into it because we had to, at least for me, and recognizing how not just vulnerable, but how everything shows. You might create your environment in terms of your consultation room or where you practice. So things like, that are often talked about, this is not necessarily talking about shame, but things that we were taught in school about, like, create your environment, what books are showing, do you have pictures, do you not, where are your tissues, all those kinds of things that, we had so many conversations about. When we went to telehealth immediately, I didn't necessarily even think about that, and then you sort of learned as you went, like, oh, wow, they can see the pictures on my wall, and it creates that vulnerability. And I think over time I have embraced that vulnerability in being able to use it more, not necessarily sharing more, disclosing more, but being able to use the comfort of that space, which goes back to how we started. I mean, when talking about shame or things that have never been shown compassion, able to not just your physical space, but being able to hold that therapeutic space is so incredibly important. So some of that vulnerability, especially here, things that have never been seen or touched or held, is so important, right? Our vulnerability is important without certain disclosures, right? It's not necessarily just about disclosure.
fascinating, right? Especially So I think that that actually transitions well to my next question, which is modulation and knowing when to intervene and when just to stay present and how to access the information about whether you're moving too quickly or if you're seeing overfunctioning happen in the client or whether you, through countertransference, are trying to rescue the client from the grief they're experiencing. Like, how do you figure those things out?
So when answering this kind of a question, like a how-to question, I always try and envision certain clients so that it helps me to be more specific, because then I feel like I could just answer so many different ways. Well, I could do it this way, I could do it this way.
Mm.
Um, I think about, so the way I'm characterizing it is sort of one of the first grief cases I ever worked with as a student intern. And then, kind of one that's more recent. Um, and so I remember going back to the tissue thing, I remember my supervisor saying from a very psychodynamic perspective, said like, you don't offer tissues, right? The tissues are there. And so in grief work, you know, often, there is some kind of cathartic experience, and sometimes that is crying, or, irregulated breathing. Um, and I remember sort of one of those first experiences with that client, and they were talking about a massive loss in their life. And all I could focus on was those tissues. Like, I'm not going to touch it. I'm not going to touch it. And I started to notice things like I was in my own mind, and it became kind of about my response. And so over time, leading up to a more current, a few years later in practice, I really do pay attention to that. Like when you talked about rescuing, because in a way that could be a form of rescuing and could stop someone from having, their emotion and expressing, especially if they've never really been able to or with anybody else. If they trust us enough to be in that space, to be able to share that, then I really do guard my rescuing based on some of my emotional or physiological response. Now, that being said, um, I think the other thing I think about in training was, do you have an emotional response? And so from varying lens of a psychodynamic perspective, historically it was blank slate. That didn't align with me in terms of my practice philosophy because my face shows everything, right? And so I think about sometimes sharing an emotional experience with a client, like tears come to your eyes. And I don't necessarily see that as rescuing, but I do recognize that physiological response in how strong the space is and how strong whatever they're telling me is about. So in terms of rescuing, going back to your actual question, um, I really, I'm a very somatic based practitioner, um, and I think I've developed into that over time, not necessarily, and using that as a strength to really recognize what is my response. And the stronger I can gauge, having at this point, knowing myself, I would say as well as I can after years of practice and supervision and, my own work, um, the stronger it is, the more I work to recognize that rescuing is still a go-to in your mind as a human being. And, I work to quell that and recognize that I get to step into my therapeutic lens and support them as a clinician and not just a person, if that makes sense.
It
And
does.
as a person, I would feel like in my personal life, you know, I would reach out and hug somebody,
Yeah.
that like a friend that was telling me those things. And yet as a clinician, I wouldn't necessarily do that.
Interesting.
So I do gauge my physiological response, not just the countertransference, but what I'm experiencing in the session. And the
Well,
stronger it is,
isn't
the
your
more,
physiological response indeed countertransference?
sure,
That's
sure,
the energy you're feeling, right? It is countertransference. It's
absolutely.
somatic.
It's not just cognitive. So I use that, and I've learned to use that, and I supervise about that. And it's not for everybody because some people don't experience the same way, um, or feel the same way, however you define that. So that's one of the ways that I certainly gauge my rescuing. And then, the other thing is I think back to training is one of the first things one of my supervisors says is, someone's going to express something and you're going to go, hey, you could do this. I I really have trained myself over time, and this at this point I feel much stronger in this respect that I don't need to have an answer, and I
Mm,
certainly don't need to have an immediate answer. So
mm,
in this case, I want to leave the space for whatever comes, and it doesn't have to be linear or, back and forth. It's the space. And so it might look messy, it might feel awkward, it might be weird. We might not know what to say. Um, so I guess I'm getting to the point where I really work to avoid rescuing, on the whole.
mhm. Interesting. I love it. Oh, sorry. I have like a million thoughts going through my head. So
You can ask.
I know,
Perhaps it will lead
we
towards the
would
other.
never end. though.
Okay.
So I know you just finished teaching your spirituality course that you do teach every summer for the MSW. So let me ask you about that. Like, what role do you think spirituality can play when clients are grieving the parts of themselves or their lives that have not felt loved? And then a second part of that question is, how do you keep that spirituality very client-led?
I guess directly, I mean, my first response is that I don't think it exists without spirituality.
Okay.
And I don't think our work exists without spirituality. And that comes from my bias in terms of, the research, the evidence, not just of teaching that class or developing that class, but now in how it's, integrated into how I practice,
Mm,
uh, and seeing it within our work, like seeing the evidence within our clients. And I think to back up a second, certainly for the lens of some of your students who haven't taken that class, is to define spirituality. The definition that I use within the course really focuses on meaning making.
mm,
And that's one of the core elements of how spirituality is defined. So it's not necessarily, certain faith, religious faith, it's meaning making within, your life. So when you think about it from that perspective, there are other factors, but when you think about it from that perspective, it 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 doesn't exist without it. You
mm.
know, any kind of work you're doing has to do with meaning making in some capacity, um, if that makes sense. And then repeat the second part of your question because I went into like
No,
all.
I love it. And a lot of this book is about exactly that. I mean, a lot of the last chapters about using ritual to grieve in community and in traditional spiritual experiences and indigenous
Mhm.
traditional spiritual experiences, worldwide, community driven. So it's absolutely a good fit with Weller's Gates of Grief. That's how you get through is through meaning making and the
And
development of
all.
common experiences of grieving. I have a client who went to a ceremony recently to grieve the loss of a pet in a family, not a friend of theirs. They have a group of friends that are like family, and one of that group lost their dog. And so they had a ceremony where they went and took ayahuasca and then shared their grief experience with this young man who had lost his dog. And she said it brought her so much relief to have that open, wide experience in which to grieve with that community of friends with whom she had this circle of trust. It was fascinating. And to see how much relief that brought her, not for the grief of this particular dog in this particular time and space, but I think for the parts of her that she never really felt had love or compassion. I think she really was able to touch some of those parts through the spirituality and meaning making they developed in community.
Yeah, and I think that, you touched upon sort of the way we often think about religion, is the counterpart is that that's within an organized community,
Mm,
organized beliefs and faiths within a community, but it doesn't have to be.
right.
However, there's so many different methods of meaning making, of focusing from a spiritual based lens. Um, and I think you're absolutely right. I mean, not only being able to share that with others, but to learn, this kind of goes back to how we started, to not learn, to access things that we didn't even know were there.
Right.
So it sounds like from this experience, this person really gained some awareness into things that they had never looked at, never thought about, hadn't touched on. And if you go back to what you started with, and the idea is that things that we either, split, put away, compartmentalize, hide, don't have never seen the light of compassion, so to speak, then, you know, you learn about yourself, you learn to develop, and you gain such awareness in that respect, especially about something that we may have earlier on in our life defined as shameful.
Mm. You said something in a conversation earlier this week about how you see so much as developmental now. So I hear that now in in what you just said, that you see that the growth and change and development they experience from this episode can be taken with them.
Yeah. And I mean, I think a lot of our therapeutic space is about, where would you like to go? What would you like to do next? Is there something you'd like to change and shift? Um,
Mm.
and so that's about, you know, maybe a corrective experience, but learning how to move forward from there, or what's next for you, what maybe has been stopping you, blocking you, have you been hiding, so to speak.
Mhm.
But yes, yes, I guess I get to say is I think psychodynamic theory and perspective gets sometimes a bad rap in terms of, kind of what it's known for and like, certain things it's known for. And yet the developmental perspective, I mean, when we look back at all the theories and how they connect to where we are today, like that's where we started. And giving that lens doesn't have to be just childhood, right? It could be 2 years ago I had an experience and I have developed since then. I am older. I have walked through a few more things in the last 2 years. So I think it's important. No, I think it's integral to be able to have hindsight and look to develop or understand foresight, and just to kind of look at things within certain parameters. It doesn't have to be like when I was 5 years old. It can be just within some kind of bookends to kind of concretely be able to look at something that is challenging for us.
It makes it like case-based, like your earlier statement, right? And if you can work with the client on a particular segment of time or space in which they had challenges, it gives them a case to work on and
Yeah.
learn things through that lens, right?
Especially if someone might be more concrete, whereas some of the things we're talking about are very conceptual and abstract. There are some clients that, that doesn't necessarily work well for. They are more concrete. So creating it within a short space, or a shorter, space of time can be very helpful. And it also lets us, let's say, when we talk about this, like things we can't touch, kind of helps us to put those aside for a second and kind of work incrementally or developmentally. And this kind of makes me think about IFS and like working with different parts. It's that same kind of methodology in that respect.
Right, right. We can partialize and concretize, and like Dr. Gonzalez always said, we can help them bite it in little bites, right?
Yes.
To
I mean,
digest.
some of the first things we talk about in terms of developing treatment plans and goals and objectives is a SMART goal. And one of the
Mm.
elements of that is, on a short term, because we're not thinking about, I find myself saying this in the therapeutic space so many times, like, let's not think about next year right now. Let's think
Mm.
about right now. Let's think about the next week or a few weeks. Because that kind of, I always point this way, I don't know why, but for the future. But it's like that space that keeps going in a very abstract. I mean, you can get lost in that, and it
Mm.
can be a rabbit hole, certainly cognitively. So kind of bringing it back to something that we can manage and navigate to start.
Again, creating a space that's healthy and useful,
Mhm.
right? Not just being a
Especially if
friend. We're not just here to vent.
No, especially for especially for spaces that are untouchable or seem untouchable, is bringing it back to something that's manageable.
And so that increases the sense of safety for that part that is so
Yeah.
exiled that it feels unsafe to return. And there's all these other parts around protecting it, right? And those are the parts that will love thinking about theoretical concepts forever instead of creating a healthy boundary.
Yeah. And maybe you start to use that as a method of distraction or defense rather
Correct. It's a
rather than
cloud.
stepping into it.
Can we see
And
the
I-
clouds?
yeah, and I think that also goes back to what we're talking about in terms of rescuing. As practitioners, you know, if we're not comfortable with that, then we might go into something like rescuing or solving or stopping some kind of cathartic experience. And we don't necessarily know that until, we ask or a client gives us something like this or doesn't come back or,
Right.
um, but we want to we want to work to navigate that as safely and as ethically as we can, I would say.
I love it. Right? And that is our role, helping them to modulate, creating that safe space in which they can have conversations they may never have before to navigate whatever's going now. So in closing, if you could tell new social workers one thing about, really what you've been talking about, which is staying present with pain and exile and those places that have not known love, what would it be? And these are all MSW students entering internship this fall.
One thing,
Well, as many things as you'd like, actually.
um,
I was trying to concretize.
thank you, thank you. Notice how I fight that.
Right.
Um, I guess the first thing that always comes to me, and this is based on, I guess, to kind of give a disclaimer, or my lens or my bias is, I really focus on the self of the practitioner. So from my perspective, it's it's to understand yourself. That doesn't necessarily mean you go to therapy. It doesn't necessarily mean, it doesn't necessarily mean anything, but that you have some sort of methodology to understand what you're experiencing within that space. Because in spaces that are so abstract or perhaps extreme emotion, if you're working with that all day, every day, and that's your niche, or that's where your agency is, and that's what everybody focuses on, or why people come to you, like there gets to be a space where you understand what's happening for you, to be able to do that consistently and ethically, um, and from a space where I think we know it's about the client, but your brain is your brain. So when your brain gets activated to focusing on that, right, on yourself, then things can get lost. And so really understanding, I would say, if I had to give something concrete about that, is understanding your practice philosophy, and that includes your use of self, your personal self, your professional self, your theoretical foundation, what are the interventions you're drawn to and how you use them, and I think also working with other colleagues and peers, having those conversations, getting supervision. That would be how I define, understanding and working to navigate that use of self, which I think is so important in this kind of work.
So the best way is by taking very good care of yourself and understanding yourself clearly, so
Yeah,
that you can remain present in the room without your own clouds.
yeah. And I think, that kind of comes down to two words that makes me think about reflective practice.
Yeah.
So however you define that methodology. So I just defined some of mine, but reflective practice, I think, is incredibly important. Whether it's talking to a colleague, whether it's journaling, whether it's yoga, your ability, again, this sort of shares some of my practice philosophy in a mindful somatic space, um, and developmental, going back to that, but having a reflective practice to do, because in your practice, you need that, in my opinion.
And then I have one more question, which is something you said right before we started, which is about how your work at Mount Sinai as part of a team was so beneficial to all of this for you, your ability to manage that very high stress, high pace environment with lots of countertransference bouncing off the walls, I'm sure. Can you talk about how that team functions so that the students can hear about a great work-life balance experience, et cetera?
Yeah, so small disclosure, I will idealize this completely.
That's okay.
What I said to Dr. McClellan earlier is that I've never had a team like that since. And I've worked on some amazing teams, and I currently work on an amazing team. Um, this team was anywhere from 13 to 17 people, all interdisciplinary of different disciplines. And we all understood our role. Um, and we understood how to collaborate. I mean, that doesn't mean we always got along. However, understanding your role, knowing that you had, the complete, like Mount Sinai really supported a complete team. And my team was based on brain injury and spinal cord injury. So, we're working with patients who are there anywhere from, a month to 3 months to 9 months, if sometimes more than a year. And so I would say the team functioned well because we all knew our roles. We were willing to collaborate. We were willing sometimes to do whatever it took because, especially for my role, finding resources for people, that just don't exist,
Mm.
and being able to ask for support. When a doctor would say to me, we're getting ready to discharge. Our discharges were planned for 3.5 weeks because sometimes it took me that long to get someone to their next step. An available bed or, some kind of insurance issue, but I was told way ahead. So being able to collaborate and knowing how to do that, you know, things like I would go and sit in the gym when PTs and OTs would work with some of the patients so I could understand what some of their needs were and they would educate me. I think that's the other key point is within collaboration, paying attention to understanding our roles and how to work with the other roles, but also being willing to educate. And so, when someone invites me into their workspace to learn what they do so that I can do what I do better,
Mm.
that was one of the key components of that team. We did not really make a move without telling each other, and because we couldn't. And I think the other thing about that, one of the beauties of working in a hospital is I worked 9 to 8:30 to 5, which is really like 8:30 to 5:30. Uh, but within that space, we were the day team and there was also a night team. And so we would sign out in between, not all of us, but there was no one for me that took over for me, but the teams that took over at night, they knew what was going on because we would collaborate and educate and sign out.
Mm.
Uh, I also worked on a team,
Continuity.
correct,
Hmm.
continuity of care, and also being able to leave at 5:30 and know that everything was being handled that needed to, or it would wait till the next morning. That was the kind of environment I worked in. Within that, not my team was anywhere from 13 to 17 different disciplines, doctors, nurses, PTs, OTs, speech therapists, psychologists, and again, everybody had a different role. The other thing was within my department of rehab, there were 6 social workers, and we all relied on each other for all of our different roles. So there were 2 brain injury social workers, there were 2 spinal cord social workers, there was me who was the hybrid, there were people that worked with, more orthopedic rehab, but we all were able to support each other. And again, educating about certain things, collaborating, sign out, relying on each other. And so what was trained as what they called 100% coverage was really about that we saw every patient, meaning social workers saw every patient that came in, not just as needed. 100% coverage really for me became defined as collaboration. And so I would say as an early social worker who thought she knew she wanted to be a therapist, starting in a hospital environment like Mount Sinai, um, I gained so much information on how to practice ethically, and how important that team support was to be able to do my job on a day-to-day basis. Because there were many cases that they would tell me about this person and the injury that they had and some of their challenges, both financially or based on insurance. And I was like, I don't know what to do.
Yeah.
And how am I going to get this person home safely when they live in a fifth floor walk up and now can't walk? Things like that. And so to be able to do my job, having that kind of team, you can see my smile and how I feel about them. I mean, some of them are still some of my greatest friends. Uh, that it it made our standard of care excellent. And it also really supported us in all of our different jobs. So it was like, I wouldn't say it was easy to do our job, but I would say it was easier. And I knew I was doing the best care I could possibly as an early social worker at that being said too. So I don't know that I think that answered your
Oh,
question about.
absolutely. It really, I think that was exactly what I wanted you to articulate was the fact that even though you were working in a really high acuity, high stress, lots of grief environment, talk about grief in the environment you were in. And much of it was tied to trauma, right? You're in a hospital, quite literally, as well as shame and family stuff that comes up around that. But because you could sleep at night, because you knew your team was strong and you were well supported in the work that you did, and you knew the work that you did was the best you could do with what you had, and your work was ethical, and you were leaving your clients behind quite literally with a team you could trust, you could do that work in a way in which all of your stuff wasn't clouding it.
Sorry about that.
Right? I
Flubbing
love
my.
it.
And
No,
I think,
that's so important, right? Because the work we do as social workers is so hard. If you're working in a trauma hospital, if you're working in a child welfare situation, I did an interview earlier today with Pamela Brooks, who's working at hospice. The work that we do, the people that we are working with have suffered, right? So if we're on a team where we feel like we're all doing the best we can, then we can be, again, we feel safe to be vulnerable and open with our clients and serve them the best we can.
yep,
It's
absolutely.
amazing. Whereas if you're on a team where, you're covering for 3 empty caseloads and you're stretched and burned out and your supervisor hasn't called you back in 12 hours, it's a lot harder to be with someone in their grief.
Yeah. And I would say, you asked me what I would say to a new social worker. I think that's the second part I would say in terms of reflecting upon this team experience that I had, and still reflect on, is that when you are going to, I feel like I say this often to students, when you're going to look at your placements and when you're going to look at jobs, I think that's a really key component, is looking around, seeing what, if you have the opportunity to have a tour of the facility or wherever it is, see what it looks like, see how people are functioning, ask that question of the supervisor. How much time will I get to spend with you? How much, does the team collaborate? Are there team meetings? Is there supervision? Like, those are things I would ask on those interviews as much as possible because I want to know how supported I'm going to be, in addition to potentially how autonomous I can be as a practitioner. But both of that balance of that duality is certainly being able to have support and knowing that your team functions that way.
Right. You can't be autonomous without adequate support.
Correct.
So interesting. Well, thank
Thank
you
you for letting me
so
reflect on
much. So interesting. Thank you so much for this conversation and for sharing with my students. I'm really
my
excited
pleasure,
to
my
see.
pleasure. And if there are, if there's other things that you think of, and I certainly would love to be an ear on the wall in terms of the conversations that come up through the semester about a lot of this.
Definitely.
Um, and I
And
would
I'll,
love to be a part of it if you ever need.
and I'll
But
give them all your contact info if they have any further questions or want to
absolutely.
ask you about your spirituality class coming next summer
Absolutely.
or the DSW.
Biased, but I think it's a great class.
Well, as the previous MSW coordinator, it got universal praise. That is for sure for the ability to really help people to look at themselves, and understand who they are,
Yeah.
both spiritually and through whatever other lens you want to.
Yeah. I think, and that is certainly, it's a course that allows you to do that, and it allows you to do that over the summer. And so some of the things that not just that I talked about, but we talked about today, and creating that space will certainly come up in that course.
Love, love. Thank you. Thank you so much. Have a wonderful day,
You too.
and I'll talk to you very soon.
Okay.
Bye bye.